from Miguel. And Dick and Sylvia, it's all yours.
Thank you very much. We're absolutely delighted to be participating. We wish we could be there. We're used to trying to be interactive, and there are clearly some technological barriers to being too interactive, but we certainly would hope that anybody who has questions, we don't mind being stopped to answer or clarify things if you can arrange a way of having that happen. We'll just sort of see how it goes. We're much too old to have any conflicts of interest. We wish we did, actually. We'll start off by, this is going to be a talk on medical education, and it's applicable to both the undergraduate and the postgraduate levels. And I think we've come to understand, we maybe always understood but didn't quite articulate it, that the central issue in learning to become a practitioner, it is becoming a practitioner, not learning about practice. And there's a difference. And that really has to do with identity formation. Our objectives, which have been circulated, are that at the end, we hope that you can describe the relationship of professional identity formation to professionalism and to place it within a community of practice, because we think that's pretty helpful. We hope you can identify factors that can positively or negatively affect identity formation. And finally, apply this knowledge to better understand your own identities and also your own educational practices.
Now, the goals of medicine, the whole idea of the dual goals is not new. Merton, who was a social scientist at Columbia in 1957, said, "It is the function of undergraduate and postgraduate medical education to transmit the culture of medicine and to shape the novice into an effective practitioner of medicine, to give him," this was 1957, "the best available knowledge and skills, and to provide him, her, with a professional identity so that he, she, comes to think, act, and feel like a physician." I think for your purposes, what Ludmer said in 2015, the really greatest influence on professional identity formation takes place during residency. And so residency is extremely important in forming your identity. So how did we get there? Well, the professionalism movement really arose in the 1980s and 90s because medicine felt a little bit threatened. The ABIM Project Professionalism started back in that time and was a seminal, produced the charter of professionalism, and which has been accepted in over 100 institutions around the world as a major definition of professionalism. Now, this led to an examination of how medicine's values were transmitted from one generation to another. And it became clear that these values are embodied in the word professionalism. Professionalism had never been taught explicitly. When Dick and I were in medical school, nobody even mentioned the name. But it was transmitted to us by respected role models. But it now has been agreed that depending on role models alone is no longer effective. The result has been a feeling that we should teach professionalism and teach it explicitly. And there have been a development of longitudinal curricula throughout the continuum of medical education that includes methods of instruction and assessment. Now, to do this, you need to have a cognitive base. You have to define something, teach it, and if you're going to access it, they have to know what it is. So the cognitive base really is definitions of professionalism and its values and characteristics. And an understanding that our relationship to society actually and the public's expectations are the ones that determine a number of the values and characteristics. So when we teach professionalism, we feel it's important to start at the very beginning. That you teach the cognitive base, the definitions, the characteristics, and the relationship social to society. And this goes on throughout education with increasing sophistication, and actually to our faculty too. We start with the definitions at the very first day of the first class, and then later on we add the concept of the social concept. But during this time, the students are having experiences. And if you reflect on these experiences, they begin to incorporate the values of professionalism.
Sylvia's just given you the schematic representation that we used to actually teach professionalism. As you will see as we go along, we've changed some of those things. You're going to see that PowerPoint again in an altered form so that it can underline how we actually attempt to support students as they develop their own professional identity. Anyhow, continuing these assumptions, we assumed that understanding professionalism would lead students to behave professionally. By the way, we've talked about professionalism numerous times in the last 20 years, and everybody always says, can you teach professionalism? Shouldn't their mummy have taught them what it means to be a professional? Isn't it the internal values? It's a very hard question to answer, and we're going to come back to it. There was an emphasis on promoting and assessing professional behaviors, on what people did. And teaching but we must never forget that the teaching and assessing of professionalism became mandatory, because it's now a requirement for accreditation at the undergraduate and postgraduate levels in most Western countries, certainly in both Canada and the United States. LCME, ACGME, our Royal College requires that professionalism be both taught and assessed for obvious reasons. But, and it's a big but, there has always been this existential question. There's a wonderful sociologist named Fred Hafferty, and he asked us a question many years ago. Does it matter why people are acting professionally? We must admit that we didn't really even understand the question when he asked it, because he was asking whether behaviors should grow out of who you are, or should you do something just because it's required of you? Is professionalism like a coat that you put on and take off? 5 o'clock, you stop being a professional, and my wife says you can then go rob a bank. Well, that's not true. Medical practice requires a professional presence that's best grounded in what one is, or who one is, rather than what you simply do. There's relevant background. The Carnegie Foundation report on all professions educations came up with a very, very solid recommendation that professional identity formation should be a foundational element in medical education. They also, by the way, recommended that it be foundational for the education of other professions, lawyers, nurses, so forth and so on. And as this happened, an extensive literature on professional identity formation emerged, mostly at the undergraduate level, which is a little unfortunate. Sylvia mentioned that we all feel that it's when you're in your residency that your strongest identity gets formed. We don't have a lot of information yet about postgraduate education, but lots at the undergraduate level. And it was proposed that supporting professional identity formation in learners become the educational objective. And that's what happened to us at McGill. Conceptually, supporting professional identity formation isn't a sort of a new concept. We build on what we've learned from teaching professionalism. The norms of the identity are outlined in our definitions of professionalism. We'll come back to that. The new assumption is, that professional identity formation throughout medical education and practice takes place through the process of socialization within a community of practice. And this process can be made more effective and reliable if we're specific about the identity to be created, if we understand the nature of identity formation, if we understand socialization and communities of practice, so that we can create a curriculum and an educational environment that facilitates the transition to that desired identity. So during this talk, we're going to talk about identity formation, socialization, and communities of practice to try and clarify what we mean under this new assumption.
Now, professional identity is different from professionalism itself. We always believe in definitions, and we go this time to the Royal College of Physicians of London, who said professionalism is a set of values, behaviors, and relationships that underpins the trust the public has in doctors, end quote. Whereas professional identity is not just how others perceive you, but how you think of yourself. We have developed a definition of medical professional identity, which we think is helpful. A representation of self, achieved in stages over time, during which the characteristics, the values and norms of the medical profession are internalized, resulting in an individual thinking, acting, and feeling like a physician. And you'll hear that term more often. Professional identity formation is really superimposed on the normal process of identity formation, which starts when you're born and continues throughout life. And usually somewhere in the early 30s, it becomes more stable, but there still are changes to your identity throughout your life. And people have several personal and professional identities. It really depends on where you are. You're a mother or a father when you're at home with your children. You're a son or a daughter when you're with your parents. You're a physician or a surgeon when you're in the hospital treating patients. You have several personal and professional identities, and it depends on where you are. The expression is context dependent. So we now are going to ask you to do a little work to talk to your neighbors and tell them what are your personal identities and what are your professional identities, and clarify within yourself and with them who you are professionally.
And we'll give you 3 or 4 minutes for this. Just look inside yourself. And by the way, don't reveal anything that you don't want to reveal. But most people actually find it interesting to look at themselves through the lens of personal and professional identities. So off you go.
Hands up. I hope you've enjoyed this. I'd love to be able to see you and see by a show of hands how many of you had difficulty separating your personal one from your professional one.
They're still talking. Yeah.
Maybe we could come to the podium. He can turn it.
Yeah.
Okay.
I guess we need to close this down. And as Sylvia said, were we there, we would ask you some of you to report. Are we? The other thing is, give a little thought.
Go ahead, Dick.
Perhaps you ask them for us if they think they can separate their personal and their professional identities.
Show of hands.
Show of hands. How many people feel that you can separate those identities? Partially. There is general agreement that it's partial, with only about a third of the audience raising their hands. So a great deal of overlap between personal and professional identities. Is that fair to say, folks? We got some head nod.
And by the way, that's the general feeling, that they're so tightly intertwined when you acquire a professional identity that it becomes part of you and it partly merges. Certainly you can tease out different characteristics that you have in your personal side, but the professional is very hard to separate. And by the way, I think that's how it should be.
Now, one of the reasons we do this for you is because when we teach our students, our residents, and our faculty, we start with this, and it sort of gets them into thinking about professional identities, and specifically their own. And it's a very useful exercise for you as educators.
And you're going to hear a lot of things today that are going to be very, very familiar to you. Professional identity, as Merton said, isn't new. People have been developing professional identities going back 2,000 years. So, how are identities formed? Well, identities are formed through socialization. And socialization is a process by which a person learns to function within a particular society or group by internalizing its values and norms. That's from the good old Oxford English Dictionary. But it's a special kind of socialization. It involves training for self-image and identity. You can be trained and acquire knowledge. That's different from developing an identity. Identity results when you meld knowledge and skills with an altered sense of self. Once again, that's from our friend Fred Hafferty, on whom we lean often. So, what's the process? This schematic representation is designed to help. Frankly, it's something that you know. All we've done is try to put it in pictorial form. Everybody enters medical school, residency, and practice. And in fact, if you change your practice or make major changes in your life, this also holds. You arrive with an existing personal identity. If you started medical school at age 2, you would have some type of identity. It starts at birth. It's who you are. And there are two large influences on that determine who you are. The first is your genetic makeup that you can't do too much about. Sex, race, you've got red hair, I have thin hair, other personal characteristics that are genetically controlled. But, and it's a big but, your life experiences have an enormous impact on who you are. Your religion, the culture within which you grow up. Somebody growing up in Riyadh is different from somebody growing up in Detroit. Your class, socioeconomic class, has a big impact. Education, sexual orientation, and you can list many, many other things that have impacted on you as you were developing and result in the person you are. You then enter, let's just say, medical school or residency, and you wish to become a doctor, and
Or a surgeon.
or a surgeon. Surgeons are doctors too. And you've got to negotiate the values and norms of the community you're going to join. We're going to get to that later. And this really involves some negotiations. And the negotiations are complex because you're negotiating with the medical profession or the medical school, but you're also negotiating with yourself. You can accept the norms, and in fact, that's the usual. You can compromise and change some norms, or you can reject the norms of this community you wish to join. You have to be careful if you're going to reject them, because you run the risk of being either marginalized or actually told that you cannot join your community. And it's here, of course, where generational differences are expressed. An example that we're all living with today. Sylvia and I worked every other night and every other weekend for 2 years, and we were happy as we could be. We didn't feel oppressed or harassed. It was in a day when average stays in hospital were 2 weeks, and people weren't really as sick. So it's a different world. But current generation, going back 15 or 20 years, places work-life balance as an important thing, and duty work hours are being negotiated every single day, I think, in every hospital. It's just, and by the way, those norms have changed as a result of those negotiations. Anyhow, at the end of the period of socialization, you actually change, and your personal and professional identities become merged. It's who you become. And we've understood for a long time that there are individual identities for students, for residents, and for practice. So you're not a fully fledged professional if you're a third-year student or a third or fourth-year resident. You become a fully fledged professional when you enter practice. So what are the norms? The norms are determined by what it means to be a professional, and that is derived from a series of social negotiations between medicine and society. Ultimately, society determines what the norms are. Our professional status is granted to us by society by delegated authority through licensing. And ultimately, society has the final say. But, of course, society doesn't understand lots of things. So a period of what are called social negotiations are taking place on an ongoing basis every single year. So definitions. Sylvia mentioned that you can't teach what you can't define. We believe very strongly about this. You have to be explicit. This is a definition that we determined. There are a lot of very valid definitions of both profession and professionalism out there. A fact of educational life is that the long ones can't be remembered, and this one is the longest we're aware of, and even we who developed it can't remember it. But it's got the advantage. It's got the advantage of being all-encompassing. It really does describe what a profession is. The shorter ones have to be beefed out and eventually you've got to cover these subjects. So this has been the basis of teaching professionalism and supporting professional identity at McGill for over 20 years. Profession is an occupation whose core element is work based upon the mastery of a complex body of knowledge and skills. It's a vocation in which knowledge of some vocation, of course, is more than just a job. Knowledge of some department of science or learning or the practice of an art founded upon it is used in the service of others. That, by the way, is straight out of the Oxford English Dictionary. Its members are governed by codes of ethics and profess that Hippocratic oath that we all said, or a modern variant. A commitment to competence, integrity, and morality, altruism, and the promotion of the public good within their domain. These commitments form the basis of a social contract between a profession and society. In return, society grants us a monopoly over the use of our knowledge base, the right to considerable autonomy in practice, and the privilege of self-regulation. Professions and their members are accountable to those served, to their colleagues, and to society. That, we think, has everything in it. If you want to extend your cognitive base, the things that you're telling students and residents that are expected of them, you also need to have, they need to have some idea of the attributes that are expected. We have taught for some time that in their day-to-day life, physicians fulfill two separate roles, that of healer and professional. And we can justify that in historical terms. There have been healers since before recorded history, whereas the modern professions only emerged in the middle of the 19th century with licensing laws, actually. So on the right-hand side are those things, the far right, that the literature tells us are characteristic of a profession. Autonomy in practice, not to do what you want when, but to be free to act in the best interest of the patient without an insurance company or a government telling you what you must do. Self-regulation is characteristic of modern professions. It requires associations and institutions to carry out those activities. Hippocrates wasn't responsible to society, we are. And of course, individual physicians up until recently were the characteristic of the medical profession. It's a team sport now, so those are characteristics of the profession. On the left-hand side are what the literature tells us every society wishes of its healers: caring and compassion, empathy, insight, openness, respect for the healing function. We usually don't heal patients, they heal themselves. We have to facilitate that. Respect for patient dignity and autonomy, being an advocate, and important, be present, accompanying the patient through their sickness journey. In the middle of this Venn diagram are things that are shared by both. Competence would be in neon lights if we could do it. Commitment, confidentiality goes back to Hippocrates. Altruism, trustworthiness, which implies honesty and integrity, morality and ethical behavior as expressed in codes of ethics, and of course, responsibility to the profession. Now, to further justify this approach, if you change that word physician to lawyer, change healer to adjudicator of disputes, the right-hand diagram, the whole circle would stay the same. The left-hand section would have some things that are specific to the adjudicator of disputes or healer. So, you know, professionalism are generic terms applied to different occupations.
So where does this socialization take place? Well, it actually takes place in social groups that are communities of practice, and you will hear more of that as we go along. If you go back to the formation of identities and put in at the bottom, people start in legitimate peripheral participation of a community of practice, and they socialize, they meet with the members, they learn the habits and the norms and the values, and they come out as full participants of this community. So what is a community of practice? Well, Vereb et al. Have said it is really a social learning theory. It is defined as a persistent, sustaining social network of individuals who share and develop overlapping knowledge base, a set of beliefs, values, history, and experiences focused on a common practice.
Now, if that isn't a description of the practice of medicine, what is?
So medicine as a community of practice is interesting. Medicine as a whole is a community of practice, and we call that the macro community. But when you join a medical specialty, family practice, orthopedics, endocrinology, whatever, these are meso communities. They're very strong one, and that's why residency is such a important part of identity formation. It's because usually that's when you get into your specialty. But then you go out to work, and you work in departments, you work in hospitals, etc., and you get into micro communities. So what has been called a community of practice is really a landscape of practices. And we legitimately belong to a lot of communities. The students and residents volunteer to join the community of practice, to which they're the residents who choose a residency in family medicine or internal medicine or obstetrics, etc., have chosen to join that community of practice, that meso community of practice. And as they join, they will acquire the identity of their chosen specialty. And by accepting and internalizing the values and norms established by the community. And as an example, my husband is an orthopedic surgeon, and he's never stopped being an orthopedic surgeon. It is a very strong identity. Now, the values and norms of the community of practice are really defined by what it means to be a profession, by professionalism. And the professionalisms vary between cultures and between generations. And if there wasn't that socialization period where new participants question some of the norms and values, there'd be no progress at all. So it's very fortunate that this socialization period is a benefit to both. And the values, but you must make explicit what the values and norms of the community are, so that the resident or student or faculty member knows what they're talking about. So you need definitions, you need to know the attributes, and you need to know the acceptable behaviors. Some of those are not negotiable. You can't negotiate caring and compassion, presence, confidentiality, honesty, trustworthiness, and so forth. But some you can negotiate a bit, such as is being negotiated now with altruism, where the need to meet the patient's, the necessity to meet the patient's needs is accepted by everybody. How they're met and by whom is what is being settled in the discussions between the current generation entering the communities of practice now. So I think you should now talk again with your neighbors and say, what professional communities of practice do you belong? And most importantly, because we'll discuss this later, is what got you into that development of your professional identities? What are the things that influenced you? And what are the things that maybe drew you back and gave you difficulty getting a professional identity? So go and talk to your friends again. And
to Lori's learning communities.
Yes.
2 more minutes. And then we'll...
Write it down.
I guess maybe we could slow down now, maybe? Even though there's
A lot of conversation.
still conversation going on, can we perhaps wrap this up?
Dick and Sylvia, would you like some questions, comments at this point?
Well, we would love to have, see if you could, if you at the podium there could ask them how many communities of practice they felt they belong to, and if then as a second point, they could talk about the major factors that influence their own identity formation.
Okay.
And by the way, questions anytime.
Who would like to respond to Dick and Sylvia's question? How many communities of practice do you belong to?
A whole lot.
The whole lot.
You heard it.
I think that's in general what most people feel. Do they feel that they belong to a large class of just physician, generic doctor?
A lot of heads nodding.
Yeah, a lot of nodding heads. Okay.
All right. How many of them identified their specialty as their main?
Yeah, what's the most dominant professional identity?
Is it the specialty or is it where you work?
Most are saying specialty.
Yeah. I haven't operated since 1981, and I still introduce myself not as somebody who used to be an orthopedic surgeon, but as an orthopedic surgeon who happens to be doing something else about 40 years later.
And I'm still an endocrinologist.
But, all right, could we hear something about what factors influence their own professional development of their own professional identities? Because we're gonna
Spend some time
on that.
Yes, sir.
Role models.
Role models.
The people you met.
The people you met along the way.
Yep.
All right.
That would be classified, I think, as personal experiences, maybe.
Or role models.
Well, they said role models.
Other factors? I'm sorry? A little louder.
We didn't hear that.
Career path.
Career path.
Where you end up and what you end up doing, even if it's not exactly where you started.
Yeah.
For some of us, it's been rather circuitous. And we may have started in a discipline, but then we worked with groups outside of our discipline, and then back again. So
Yeah.
Career path can be quite variable.
Mm-hmm.
Okay. Well, thank you very much.
Thank you.
And that coincides with other groups. So now we're going to go and tell you what the literature tells us about how socialization takes place and the factors that impact on everybody. Again, what you're going to see, every single one of the little boxes that we're going to show you is something with which you're familiar. So this is going to be a complicated diagram, but it really isn't. We're outlining the process of medical education in another way.
And We would love at the end, if you think we've missed a factor,
Yeah.
please let us know.
But
And we will add it.
But as you said, the first person said role models, and we would extend that to role models and mentors because they're very close in terms of their impact. And you heard both career path, but also the experiences you've had going along. The literature, not just in professional identity formation for medicine, but for identity formation for other aspects of other societal roles, is absolutely adamant that role models and mentors and clinical and non-clinical experiences are the dominant factors that influence people. Both of them function through both conscious and unconscious means. Obviously, role models, if you're consciously looking at a role model who's either good or bad, by the way, you can say, I wish to be like that person, or I do not wish to be like that person. But it's interesting, the literature on workplace learning and role modeling is pretty solid in indicating that the majority of influences are actually unconscious, that this results in not explicit knowledge, which is the result of conscious reflection, but tacit knowledge. Tacit knowledge is that which you know but cannot tell. You're not aware of it. We like to tell the story of a chair of surgery in our institution who was named to replace a long time and very charismatic chair. And very rapidly, the new chair started to walk and talk and yell and scream like the old chair. It was interesting. And if we had told him that, I'm sure he would have been terribly embarrassed. And yet it was absolutely real. The same thing happens with experiential learning, the clinical and non-clinical experiences you have. And by the way, in medicine, the literature is absolutely adamant that the earlier you have clinical exposure, the more you start to feel like a doctor. That even first-year students, knowing nothing, being terribly uncertain, playing a role, will start to feel that they're on the journey to becoming a professional, if that happens. So clinical experiences are absolutely dominant, but other experiences also have an impact on the development of your new professional identity. Formal teaching and assessment certainly has an impact. Those of you who have done any reading in the field of medical education will know that there's a very large literature now on the impact of the hidden and informal curriculum, which is that which is not specifically taught. What we have done with both professionalism and now professional identity formation is flip them from the informal curriculum to the formal curriculum, and it has an impact. It provides them with a cognitive base and a language to use, for example. And of course, assessment and feedback as to whether you are mastering it has an impact. If your feedback is all negative, your identity formation will be retarded. And the other thing that's important is self-assessment. If you think back to what we said earlier, that identity formation is represented by not just what other people think of you, but what you think of yourself. Self-assessment becomes very important. Now, we know that self-assessment in terms of skills and stuff is notoriously unreliable. That bright people underestimate themselves and people not so bright overestimate themselves. But when it comes to assessment as to whether you feel more or less like a doctor, you're the only person who can do it. So self-assessment, guided self-assessment becomes important and has an impact on identity formation. The learning environment is absolutely crucial, and it can retard professional development. We all know that. And positive learning environments where the values of the medicine are seen to be supported, where good behavior is rewarded and unprofessional behavior is not tolerated. This has a big impact on professional development. Sorry. The healthcare system is something, it isn't the job of educators at any level to change the healthcare system. They can try, but that's not the thing. But it's really important that every learner at every level understand the impact of the healthcare system on who they are, who they wish to become. We turn out young idealistic people into healthcare systems that don't totally support professional values. We all know that, and our system is a little different from yours, but we still have issues like that. Learners have to, they don't have to, it's not their job to go out and change it, but they've got to understand, for example, your learners have to understand that they're entering a competitive marketplace and that this will have an impact on their professional values. And they need to get some control over things like that. Family and friends certainly have an impact. Every medical student will tell you that when they go home for Christmas and people start asking them medical questions, that they start feeling like a doctor. And the same thing with their friends. It's a big factor. And of course, linked to that is isolation from peers. Medical students have, and other law students are the same, have been isolated from their previous environments for generations. It is a negative factor, but it also, again, as the sociologists will tell us, that when you're isolated with a group of individuals who are devoted to the same purpose, you tend to identify with those people and acquire an identity together.
You join a community of practice.
You join a community of practice together, and it's that social interaction that does it. So isolation, we will never totally get rid of isolation. I think we have come to understand that it has a negative impact. Attitude of treatment by patients, peers, healthcare professionals, the general public. I referred to that earlier. How you're treated does have an impact on how you regard yourself. When people start thinking you're a doctor, you start feeling you are too. And of course, there are the traditional symbols and rituals that have a really solid impact on identity formation. That Hippocratic Oath is something most of us have never forgotten. Our first contact with death, maybe our first stethoscope, the white coat ceremony that's now in most medical schools, where family and friends get together and you sort of officially start to join that community of practice symbolically by putting on a white coat. That has a real impact on how people feel about themselves. And then finally, and this one's new, social media impacts on socialization. The literature on social media is sort of interesting. It started about 10 or 15 years ago when social media became omnipresent. And it was largely negative because it recorded breaches of confidentiality and the projection of unprofessional persona on social media. We have come to reevaluate social media, and frankly, we can't have a negative attitude anymore, simply because it is everywhere. Every medical student, every resident, and every physician younger than Sylvia and I uses social media every single day. They use it to learn. They use it to build communities. They use it to diminish isolation, and it's a part of their lives. So we now have to acknowledge that, and frankly, we are now using social media as a means to impact on socialization. And we're just starting to figure out how, but we still must insist that you don't have total freedom to put on social media what you wish. So that's the story. And again, coming back to where we started, in spite of all of those multiple factors, role models and mentors and experiential learning are the two most positive ones. And of course, every single learning environment will have its own factors that we don't sort of understand totally, and you have to look at yourself. Something to mention here is that the acquisition of a professional identity does not proceed in a straight line from entry into medical school or residency. It has ups and it has downs. Not only that, these factors that we have outlined, that by the way we drew from the literature, we didn't make them up, they will impact different individuals in different ways. You know, there are some people for whom formal teaching just doesn't work as well. There are some people where attitudes is a huge impact. Everybody is unique. Their own identities are unique, and frankly, their professional identities are unique too.
So how do learners respond? How do they cope with all these different factors that are hitting on them? Well, to go back, you come with your own personal identity. You get socialized and come out with a new personal and social and professional identity. And a lot of it is the beginning is learning to play the role. You will be put into situations and have to pretend you know what you're doing. Pretend that you're a doctor when you're a student. Answer the patient's questions. And of course, the more you do it, the better you get at it. But even in practice, you will have to pretend sometimes because you won't know the answer when the patient asks you, and you will go find it out. But you can tell them, I don't know, I'll go find it out. But you do have to pretend that you're still in control. Now, you'll have to learn the language, and that's part of what leads to your isolation from your friends. But it is important for you to know the various terminologies and practices and be able to describe them. You have to realize that it isn't a black and white practice. You're going to have to realize that there are sometimes not really good answers. It's the best of the worst. And you will have to live with this ambiguity and still be able to sleep at night. You will have to
Learn the hierarchy.
Learn the hierarchy and
Power relationships.
And power relationships. I better go on here. And power relationships, because they exist. There are always hierarchies. There's always somebody who knows more than you are. There's somebody who is the head of the department and you're not. There are hierarchies in every context you're going to put yourself in, and you have to learn what they are and how you're going to deal with them and how you're going to deal with your peers, whether you will be cooperative or whether you will not. There are a bunch of things that are difficult.
There are various ways that an individual can react, and they're predictable, and medical students react in predictable ways. Detached concern has been recorded for generations in medical students, as has loss of innocence, cynicism, and of course, either gallows humor or actual silence as you go through difficult phases. Now, anxiety and fear are a normal part of changing your identity. When you are changing your identity and adding a professional identity, the literature on identity formation outside of medicine is absolutely dead on that you cannot change your identity without stress. Erickson, who was one of the pioneers in identity formation, coined the term identity crises many years ago, says that there is absolutely no way you can change your identity without stress. Lynn Monroe, who's a current researcher, talks about identity dissonance, when your old identity conflicts with the identity that either other people wish for you or you wish for yourselves. So anxiety and stress are an essential part, and fear and frustration go with that. Now, if we talk about stress a little bit, there's a big literature on stress in medicine, and it's all largely negative. But we must go back to the fact that if you go back to 100 years, the first stress curve came out, and stress is beneficial to performance up to a certain level, at which it plateaus, and then it becomes corrosive and performance deteriorates. We've got in our educational institutions to try and manage that stress level so that it doesn't get to the negative side. The literature also is kind of deficient because it doesn't record the fact that as you realize that maybe you're going to make it, that there's satisfaction and even joy. And this is something that we actually learned as we were giving a workshop at a European meeting, and we didn't have this satisfaction and joy. And somebody said, where's the fun? Where's the joy of becoming a physician? And we realized we were wrong. What the literature does tell us, however, is that one of the most important factors that makes you feel like a physician or any other profession is when you realize that you're becoming competent. And this has an impact directly on your identity, but it also, of course, is responsible for that satisfaction and joy. So those are those two schematic representations actually resume a resume of a whole lot of literature on medical education, and we've covered, I think, as you realize, a lot of things, but every single one of those boxes, nothing in that is new to you. There are no new terms. These are the factors that impact on people.
And we tell these to the students on day one so that they know what the factors are that are going to be playing on them, and that some of the responses that they're going to have are normal, that they don't have to worry about being abnormal or sick or whatever if they find that they're feeling not quite as innocent, that they've lost their concern and so forth. Now, there are some criticism of communities of practice, and I think probably Bourdieu is the one who put it best. He said social structures tend to reproduce themselves, perpetuating existing hierarchies, power structures, and inequities. Quote, self-deluding and self-reinforcing social behavior can take place within communities of practice. And I think this is something we all have to be aware of, and it's something we have to identify as we become stiffer and stiffer in our thinking. So identify and address the issues, whether they're because of socioeconomic changes, gender, race, hierarchy, power, all of those things you have to be very careful. Now, the whole process of socialization can also react inappropriately on certain learners and suppress very important parts of one's personal identity, and this leads to great dissonance. And faculty have to help students through these because they will all, to a greater or lesser extent, have a period where their suppression of their own personal identity is threatened. And we have to be aware and make sure that this does not actually become a major negative aspect for them and help them build the new identity on top of their own identity.
People must be able to go through medical school and remain who they are. And I think that requires conscious effort. So we're going to close afterwards with what the literature tells us about how you can specifically support identity formation in students or residents. We would be grateful if you could discuss with your neighbors what approaches you think could be taken, and then we'll, for about 4 or 5 minutes, and then we will tell you what the literature says
That might help.
That might help. So again, away you go. Okay, I guess we should start again. Just, are we ready?
Yes, no.
Okay. I'll start off by saying that there is a movement in many medical schools to officially have programs devoted to identity formation as a very fundamental part of their curriculum. We've been doing it for about 7 years. NYU has done that. The entire University of Texas system with its 6 medical schools is involved with attempting to build their curriculum around identity formation. And because 90% of their medical students do their undergraduate degrees at the within the University of Texas system, they are actually going back into the undergraduate level to try and start awareness programs about identity formation at the undergraduate level. So, and as we mentioned earlier, the Carnegie Foundation report states that professional identity formation should be foundational to medical education. So what we're talking about is a reality in some schools and is maybe something that others are discussing. But our guess is it won't go away. Its total future will depend in part on accreditation programs. We mentioned earlier that the teaching of professionalism was made mandatory because every accrediting body now requires it. Assessing progress towards identity formation is difficult, and every regulatory body is not interested in things that it can't assess well. So we'll see how far we go. But what we're now going to do is finish off by just telling you what we and others in the literature have learned as general principles for supporting professional identity formation. In the first place, establish it as an educational objective. And the minute that happens, it has to become an aspirational goal for both students and faculty. Explicitly embrace communities of practice as the educational theory underpinning medical education. I think we've come to understand that there must be educational theory under sound educational practices. And communities of practice is the most robust theory that can actually serve as an umbrella. You can use other educational theories, but they work within the communities. For example, there are educational theories on role modeling. There are educational theories on experiential learning. But those two things happen within the community of practice. And it helps faculty in particular, but also learners, understand what's happening. Institutional support, that sort of goes without saying. Anytime you don't provide institutional support, things aren't going to work. Allocate responsibility. Most medical schools will have a committee responsible for professionalism and professional identity. They usually have different committees for undergraduate and postgraduate because the accreditation procedures are different, but the principles are the same. And then we get to the stuff where we find people are most usually deficient. Establish and explicitly teach the cognitive base. Establish and explicitly teach the cognitive base. Pick a definition. Communicate the norms. So you've got to pick a definition, and you should tell your learners what's expected of them, the attributes. Tell them what's going to happen to them. We use those schematic representations to give to our students on the first hour of the first instruction on the first day of medical school. These are the things that you are going to go through. We're going to help you, but you need to understand it. Tell them they're joining a community of practice. Make sure that the faculty understand the nature of a community of practice. And so that original diagram that Sylvia showed you several hours ago, I'm sure you think, has been changed so that imparting the cognitive base is still there, the role of the healer and the professional, but we put in socialization, professional identity formation, and communities of practice. And we now talk about the capacity to develop a professional identity. A first-year student has had far less exposure. Frankly, his own or her own personal identity is not as well developed as a fourth-year student. They're older, and the normal processes of development have occurred. So those are the changes that we made to that. Provide faculty development, because these, most of the time when you talk to faculty, you're talking about concepts that they understand. But socialization, identity formation, and communities of practice are new terms for them. So it really is essential, if you're going to have a successful program, that you have a faculty development program. And really important, and that's why this is the first day of instruction that we have, engage students in their own identity formation, establishing membership in the community as an explicit aspirational goal. Stress that students must retain their own personal identities in spite of dissonance. And that's important for faculty to understand. You know, there's always a tendency for professional schools to take a cookie cutter approach, that everybody has to be the same. They don't. They have to have some common characteristics. And again, where I think many places fail is be intentional. Provide regular time and opportunities for guided reflection on professionalism, identity formation, and communities of practice. Regular time and opportunities into busy schedules. It's not easy, but it's essential, because reflection is the means through which people can get intentionally socialized. Ensure that the community of practice is welcoming and supportive. Role models, mentors, institutional factors. Emphasis on continuity, social events and rituals. Do it intentionally. Set up social events to bring the students, the residents, into the community that they wish to join. And finally, establish programs to assess progress towards the acquisition of a professional identity. going back to what we said earlier, that professional identity is both how others view you and how you view yourself. It isn't easy to assess progress between joining the community, being a layperson and then a doctor. But if we assess professional behaviors, we can assess how others see you. And if we stress guided self-assessment, we can assess how you see yourself and make people reflect upon it. And we have a mentorship program where we ask students how far they feel on the journey between layperson and physician. And where are you on the journey, and what factors have made it easier or have impeded you on this journey? And this combination can help. The aspirational goal, a shift in emphasis from us teaching and students learning to one in which learners are actively engaged in developing their own professional identity, and the role of peers and faculty is to support this journey. So we're going to close with a quote from a wonderful researcher. Expertise is not simply a property that passes from teacher to learner, but a dynamic commodity that resides with a community of practice. Learning, according to theory, is a process absorbing and being absorbed into the culture of such a community. So that's what we're really trying to do. And we thank you very much. And we've got some time for questions. Over to somebody.
For questions.
Okay, thank you, Dick and Sylvia. Very helpful. About some comments, questions on these concepts? Thoughts on how you might, over here.
You mentioned that the health system is something that we can't change very much. But I'm wondering, in the process of developing professionalism, the idea of leadership and being able to change your community, your health system, and advocate, how do you see that as part of that process?
Can you,
Could you repeat that question, please?
Sure, I'll try my best. You talked about the difficulty of changing health systems, but as people develop professional identity and leadership, how might that affect the whole systems that we're working in? Fair enough?
Well, yeah, that is a very interesting question. I guess
There's no quick answer.
there's absolutely no question that we require leaders from within medicine to serve as advocates for change in healthcare systems. And by the way, I think we all understand that there's no perfect healthcare system anywhere in the world, that every healthcare system can be better than it is. And that it's almost inconceivable that a healthcare system would be changed without significant input from leaders in medicine. I think that when we're talking about an undergraduate or postgraduate curriculum, that you certainly try and identify leaders, but not everybody is, but it can't be a requirement of everybody. So I guess while this is question's a little oblique to what we've been talking about, identify the potential leaders within your system and make them aware of the issues and support them as they learn
Fight for you.
Yeah, as they learn how to lead and become involved in the process, which
is basically, in some ways, changing the social contract. This is where you negotiate with society to get the changes. Politicians move because they wish to be elected, and that they get elected by what society wants. Get society to want what you want. And this is through talking to your patients, through talking to other people, whatever, but getting the public aware of what changes need to be done.
But leadership is no matter whether it's within the medical profession or acting on behalf, is essentially a political process when you're dealing with healthcare.
Other comments, questions? Okay, this is a good start. We've got a break now, and there's also the handout on reflection and reflective capacity. Folks, how about if you take 15 minutes, and thanks again to Dick and Sylvia.
Dick and Sylvia, if you'd like to stay on and comment, love that. If you have to leave, that's fine.
We'll be here.
We'll be here.
And Danny, can you let me show my desktop to Dick and Sylvia then?
Sure.
What was that?
Yeah, it's going to stop sharing.
Okay.
Oh, okay.
I gotta get it up here. Let's see.
Now you would have to share yours, David, through the Zoom meeting.
That's the one I want.
At the bottom.
I know. I'm just gonna do the title page. Just the title page. Yeah, I got it. You're off
The
here.
title on it.
Yeah.
And just, no, hit down here.
There you go.
Yeah, I know.
Oh, good.
There.
That's perfect.
That's not gonna work.
Why not?
Can't see my page.
Okay.
Now you will be
I
able to
can't.
see this because he has.
These are the same.
Perfect.
There we go. Yeah, but see there, back there. There we go. It's not gonna do it by itself, is it?
No.
Oh, okay.
Okay.
That's
Larry,
perfect.
Danny, can you see our?
Yes, we can.
Okay,
Dave.
we're good. We're good, Larry.
We're good.
Are we live or?
Yeah.